Greetings, everyone. There we go. Greetings, everyone. Marco Polo.
Speed of processing. Gigahertz. Hey, Steve, it's MK. Are you on?
I am. I'm just setting things up.
I got a quick question for you.
Shoot.
For Christmas, I got an authentic bottle of Tennessee Black and Tan. What's the best way to drink it?
Is that a bourbon distillery?
It says it's whiskey distilled from malt mash.
Six in the
So I'll be honest, I'm not familiar with that exact one, but I'm looking at it right now because you had me curious. It's got some, it's approximately same alcohol by volume as bourbon. Technically, it's not a whiskey, but it's similar to a whiskey. So I would say drink it neat. Neat and sip it would be my guess, what you do with most good quality Tennessee whiskeys and Kentucky bourbons. And it says on my website that it is rare. So somebody gave you a treat. I don't know what the cost is, but congratulations.
Oh, well, thank you. Maybe I'll treat it like a new member of the family.
I'm one step away for a minute. I'll be right back soon. So anybody pops on, just tell them we'll be started here momentarily. And Justin says use granite tubes. You know, have you ever done that, Justin? Because I have, and I'm not impressed.
Yeah, I use it when I'm the same way. I don't mind using a little bit of ice on them. But I mean, a lot of people that want to be purists say to use the granite cubes because it doesn't water it down. I actually like a lot of times, especially for the bourbon whiskeys, to water them down a little bit with ice.
Yeah, you know, I would rather just drink it in a chilled glass than water it down, or just drink it neat at room temperature. I mean, don't get me wrong, ice isn't bad, but if I'm going to put ice in, I'm going to do a bourbon and Coke rather than just a straight bourbon. So
Right. Yeah, if you're drinking that 12 or 15-year-old good quality scotch, yeah. I never thought really too much of the chilled glass technique, but that's something I might have to look into with some of my good scotches.
yeah, I mean, I'm saying if you want it cold, which is purely optional, that's just personal preference. Anyway, I'll be back in a minute.
nice.
Good morning, PARM 223. How are y'all doing?
Right?
Good.
Doing good today.
All right. Looks like everybody got the word that we are doing online, or looks like most people have. I hope.
I know some students are having issues when they click the link, it says no data.
No data? That are they trying to do it on their phone? That sounds like
One
a
of
phone
them
issue.
is having that problem on their laptop. The last person just switched to their laptop right now from their phone.
I am here now, Steve. This is
Oh.
Brianna Benjamin.
Awesome. Okay, so the first thing I'm going to ask everybody to do, if you know where the chat box is, I want you to go in and clearly type your first name, last name, and which campus you're from. That will be our attendance roster for today. First name, last name, etc. Got it. Everybody's punching those in. That'll make life a lot easier for everybody. Idaho Falls, can you all hear me?
Yes, sir.
Copy
Okay.
that.
Okay, I see the classroom there. Are people in the classroom too, or are you logged on separately? Or is it, I want to make sure that there's nobody we're missing somehow who's just watching through the normal classroom.
I think we're all on Zoom today for this class.
That's correct. You should be, but I want to make sure that we didn't miss somebody somehow. Okay. All right. Well, I'm going to get started here. So first thing is, are there any mics in the audience? Oh, I already did that joke. Damn it. Never mind. I already did that joke with you guys. Okay. All right. Let me pull up my screen here. I close out some of my windows. Zoom meeting. Yeah, don't close the event one. All right, so I'm going to share my screen. Does everybody see a picture of? Oh, wow, I got subtitles turned on. That's pretty cool. Okay, does everybody see a picture of Sting from the Police on there?
One of the most beautiful men in the world. Yes.
Besides me, I understand. Is anybody not seeing Sting up on the screen?
I am not seeing it.
Okay, so it says I'm sharing. Brianna, are you on your phone or on a?
I'm on my laptop. It just says every breath you take. It's
Yep.
like the introduction, but I don't see a police anywhere.
Well, when I say police, it's this might be before your time. Sting, the man, the face you might see up there was the lead
Oh.
singer of the band Police.
Oh, okay. Yep. I see him.
Oh, it's gonna be one of those days.
That's awesome.
Thank you.
What's his real name, Steve?
Oh, I don't know what his real name is.
I believe it's Gordon Sumter.
Okay, well, we'll have to look that up. Okay.
Sting is much better, MK. I agree.
Yeah. Okay. So let me make sure I get the chat box up. So I have a lot of things up on the screen trying to monitor everybody, but I'm just going to tell you that it's always possible I may miss your chat or something like that. So if you feel the pressing need, please feel free to catch me in audio so that I answer all the questions. Okay, there we go. Okay, guys. So real quick, are there any questions about this week's module, this week's unit so far? No questions. Okay. How about the discussion board or anything like that?
I have a question.
Yes, ma'am.
Is it okay if we kind of exceed the word limit by a lot just because there was a lot to elaborate? Like, you're not going to mark us down for that?
I will not. No. Nope. No. Not unless you're just, if you were, for say, just copying huge blocks of text from your sources or from an unsigned source and just putting it up on the screen, you might get counted off for the material you put up, but you're not going to get counted off for the word count exceeding it, rather. Does that make sense?
Yes, thank you.
Okay. All right. Perfect. Okay. So let's get rocking. So this lecture is going to go over vents. Now, this kind of builds on what we started last time with tracheostomies and so on and so forth. So a lot of the material will give you a good overview of what you can expect going into RT rotations. This will not be comprehensive. As we know, we can only do so much in the hour and a half to 2 hours that we're given. But it's a good overview, and I would encourage you guys to do additional research on your own. As a matter of fact, if there's a lot of great resources out there, there's a really good, well, let me back up. There's a good introductory vent course on a web page called Flight Bridge Ed, but they want about $90 for it. But if you really want to dig into, get a good basic introductory understanding of ventilators, how they're used in critical care, transport, and stuff like that, it's a pretty decent course. And they sometimes have specials on it. And there's other courses out there too. Sometimes you can get them for free. But we could spend, I actually designed a course that was a semester long just on mechanical ventilation, just as an introductory for paramedics. So we could spend a lot more time. This is going to be an introduction for you, though. So this is going to be our learning objectives for this. We're going to describe mechanical ventilation. We're going to talk about all the different types and subtypes. We're going to talk about when you would use it. We're going to talk about some definitions and terminology you should probably have be pretty familiar with. We're also going to talk about complications, and I didn't put on here, we're going to talk about some basic troubleshooting. So we talk about ventilation and respiration. Something that's probably worth talking about is that these are actually two separate processes that happen to occur in the same place and time. So for the firemen that are part of this group, how would you describe ventilation? And there's a specific reason why I called you guys out for this.
I have a feeling you're referring to the facts of like ventilation for like roof ventilation to get oxygen into the fire.
Actually close. I was more referring to like when you ventilate a house, when you ventilate a roof where you allow heat to escape, where you allow toxic gases to escape.
Yeah, that's what I was talking about.
Yeah. So that's ventilation, is the removal, where respiration is the transport of oxygen and other vital nutrients to the cell, and the actual, physical respiration, cellular respiration that occurs back and forth. So we often use these terms interchangeably, but they are a little bit different. So as you progress in your and grow in your understanding of mechanical ventilation, understand that moving air in and out is only part of the process. It doesn't address pulmonary perfusion. It doesn't address alveolar, the distance between the alveolar wall and the capillary wall. It doesn't address what happens after the blood cells pick up the gas and how it gets it to the target tissue, or any of those type of things. So mechanical ventilation, while is exceedingly complex, is still only half of the battle, so to speak. So remember that ventilators don't breathe for the patient, even though we often use that term. The patients actually do the breathing. Ventilators just move air in and out. And a cycle, when you talk about a ventilatory cycle, it's one inhalation and one exhalation. One inhalation and one exhalation. And in the ventilator or respiratory world, they often call these breaths mandatory or assisted or spontaneous. And if you're on the other side of the pond, sometimes they call it inflation instead of ventilation. But somebody out there from Idaho Falls, tell me what you think mandatory ventilation would be.
Perhaps ventilation that needs to be done because the person is not breathing by themselves.
You're not too far off, but not correct in this particular context. Somebody else take a stab at it.
Like a patient that has been RSI'd that has to be mandatorily ventilated?
No, not quite. So
the ventilator has a set number of breaths at a set interval that it has to give.
Exactly. So mandatory ventilations are ventilations you have programmed into the ventilator. And again, we're talking about this specific context. These are mandatory ventilations are breaths that you have programmed into the ventilator that it will give come hell or high water to the patient, depending on other settings. So if you have 10 mandatory ventilations programmed into the ventilator, it will give 10 breaths at even intervals over that minute. Does that make sense? Sometimes in Zoom, you gotta talk. I can't see you shake your head with all the other stuff I have up on my screen. Is it we good?
Yes.
Outstanding. Okay, so with that in mind, what do you think assisted ventilations is? Somebody who did not answer previously.
That would be a human hand pushing air via like a bag valve mouse LMA.
We often use that term for assist. We're going to assist our ventilations, but not in this context. Specifically tied to ventilators. What do you think assisted ventilation might be?
Maybe the patient is able to breathe a little bit on their own, but needs a little help to get the full breath.
Bingo. So what we have here is maybe the patient's able to take a small inhalation and then the ventilator assists them the rest of the way. So what you'd have is maybe something called a trigger. And the trigger is set at a certain inspiratory level, usually set by referred to in liters. And in essence, if they pull enough inspiration in to breach that threshold of that trigger, maybe the patient only has breath strength enough to breathe about 250 to 300 cc's worth of tidal volume, but you have a minimum tidal volume set at 500. The ventilator is going to assist them up to 500. Or maybe you have it set to a certain pressure, an airway pressure instead. You'll hear this talked about when we talk about pressure support. It will assist them up to that peak airway pressure, whatever you have that level set at. So the patient starts the breath, the ventilator assists that to a certain threshold. What's the definition of mandatory again? These are breaths that the ventilator will give regardless of what the patient does. So if you set the ventilator at 10 breaths per minute, it's going to give 10 mandatory breaths a minute, depending on your other settings. Spontaneous breaths are essentially breaths the patient takes on their own. They may or may not trigger assistance from the ventilator, but these are the patient's own inherent respiratory drive trying to breathe. Does that make sense, everybody? Okay. Is assisted like BiPAP? No. And we'll talk about BiPAP at the end of this. Okay, so these are some abbreviations. I'm just going to hit some of these, so to speak. Let me get my little laser pointer here. So ACV is assist control ventilation. We're going to talk about that. That's a mode. BCI is breathing circuit integrity. CPAP and BiPAP are forms of positive airway pressure. And the difference with BiPAP and CPAP, also known as bilevel, is that these provide increased airway pressure, but they don't actually provide a ventilation. So the increased airway pressure decreases work of breathing, but if they stop breathing, BiPAP or CPAP alone will not breathe for them unless the ventilator is set up with a backup mode in case the patient stops breathing. The rate, when they talk about rate, is ventilatory rate, number of breaths per minute, i.e. often mandatory, but not always. You'll see us talk a lot about, and I actually responded in a couple of the discussion boards about this, the I to E ratio. I to E ratio. And you can look up there, or you can just try to guess. What do you think I to E ratio is? Anybody? In Captain Dummy speak.
How long the inspiration part of the ventilation is, and then how long the expiratory phase is.
So we measure this in seconds. So if I have an IED, somebody different than MK, I think that's MK. And thank you, MK. I'm just trying to distribute the level a little bit. If somebody has an IDE ratio of 1 to 2, what does that mean in practical terms?
1 second of inspiration, 2 seconds of expiration.
Right. And if I adjust that to 1 to 4, what does that mean?
1 second of inspiration to 4 seconds of expiration.
Yeah. So we allow more time to exhale, and there are some advantages to that. Because a lot of times, if remember that when you have somebody, especially if they're intubated, they're a closed circuit. So no air moves without the ventilator either permitting it, triggering it, or otherwise assisting it, right? So if you don't have an IDE ratio set up, it usually defaults to 1 to 2, which means if the patient actually needed a 4-second exhalation time over that breath, they're not getting it unless you set it up that way. Now, something else to keep in mind, in respiratory therapy, let me back up. In EMS, sometimes we spend a lot of time focusing on tidal volume from breath to breath. And that really is a one-dimensional view of a three-dimensional problem. Another dimension is minute volume, and I have that on here, MV, minute volume. So minute volume is your air movement over a minute. Now you think, why would that be more important or as important as what we do on tidal volume? So somebody, I'm going to pick on somebody from the Meridian campus. Give me a practical Captain Dummy version of why we are concerned about minute volume compared to tidal volume.
Can I answer again, Steve?
Let's give it a second here, see if somebody else. And it's okay if it's okay to be wrong. Let me just stress that. I want you guys to work your brain around this.
I would say the main concern is, I guess, like, in the best way I can describe is like consistency, right? Just they have an adequate tidal volume per breath doesn't mean they are adequately oxygenating themselves, depending on like their rate and everything like that.
I would take it one step further. I think you're 90% there. The other 10%, and somebody put in the equation in the chat box, tidal volume, and which is actually VT, not TV, by the way. Tidal volume times respiratory rate equals minute volume. So tidal volume, if your tidal volume is 500 cc's and your respiratory rate is 10, then your minute volume is 5,000. Everybody got that? So to expand on what your what you're saying, you're worried about whether the respiratory rate and stuff is adequate. It's question is if it's adequate for their needs. So we can, a lot of times patients will get as part of their medical orders, as part of what their patient care plan is, they'll be prescribed a minute volume of, we'll just say 5,000 cc's a minute. So if you adjust down their tidal volume as a lung protective strategy, but for some reason the physician or your orders think they need 500 cc's a minute, then you need to compensate by increasing the respiratory rate, or vice versa. It's a balancing act. Does that make sense? So minute volume is really kind of representative of what we anticipate their physiological needs for airflow is going to be. And we need to adjust the tidal volume and the respiratory rate and other parameters to meet that. Does that make sense?
Yes.
Okay. Does anybody else
Yes, it does.
have a comment or question about that?
I guess I was thinking about also building up the interthoracic pressure and what that would do. Like if their tidal volume is such and you're forcing a minute volume of a certain volume, that would increase the interthoracic pressure to a point that it might be detrimental to the patient.
It could, but there's some other ways you can adjust that also. So maybe you decrease your tidal volume. Yeah, you've increased your minute volume, but with decreased tidal volume, you also increase your exhalation time. So you still allow for adequate time for that gas to fully escape the chest.
So what about if their tidal volume is too low to the point where they're almost hyperventilating instead?
So again, that comes back to adjustment based on your blood gases, and you all have had blood gases, PaO2, PCO2, and stuff like that. It also, they match that up with your end-tidal CO2 and your airflow. And they also, if in true critical care units where they have, and they don't do much hemodynamic monitoring anymore compared to what they used to, but they could actually monitor your central venous pressure with something called a Swan-Ganz catheter, and gauge the effects of your ventilatory rates on that, on your blood pressure and such, your central venous pressure. So they actually take all those different data points to come up with hopefully what is the ideal mechanical ventilation strategy for the patient. But yeah, it is possible that you could underventilate them. Matter of fact, let's take that a step further. What do you think happens if you don't ventilate your alveoli enough? There's a name for that condition.
Atelectasis.
Atelectasis, yep. And by the way, it says if you don't ventilate your alveoli enough. I love these. I don't know if you guys are seeing them. I love these subtitles that are popping up across the screen.
I think it said raviolis for alveoli.
Yeah, yep. It's. I feel like I'm President Trump speaking, or the former President Trump speaking. Some of the stuff that comes across this. But anyway, all right. So you'll notice sometimes, and I got this right up here. I'm jumping around a bit where it says MV is minute volume, MVE, minute volume exhaled. And there's also a minute volume inhaled. There's also a tidal volume exhaled and tidal volume inhaled on some vents. What would be the benefit of having a tidal volume exhaled and a tidal volume inhaled, or a minute volume exhaled and minute volume inhaled, as far as a number?
Could that do with the pressure, the intrathoracic pressure, making sure that you're kind of getting out as much as you get in so you don't build up the thoracic pressure?
That is exactly that. So if you are putting in 5,000 cc's, I'm just going to use that number because it's a good generic number, 500 cc's times 10 breaths a minute. If you are putting in 5,000 cc's, but you're only getting 4,500 out per minute, you have 500 cc's somewhere that's unaccounted for. So that might give you a low early warning. You also have things like your actual airway pressures that will give you a warning, and what we call plateau pressures and stuff like that. that we won't get in too much today that can also give you a warning that you're trapping air. Your peak airway pressure is literally the airway pressure in the ET tube. So if it builds up, what that tells you is that you're trapping air, or that there's something else that is meaning you're having to ventilate at higher rates. Now, sometimes that isn't just trapping air. That's because you have sick, non-compliant lungs as well. PEEP. Somebody from Idaho Falls, give me 1 or 2 sentences to describe what PEEP is in all of its various flavors.
So that is positive end expiratory pressure, and it just makes it so that the alveoli stay open by not allowing a certain amount of pressure to leave the body.
Yep. So it basically keeps just a little bit of residual pressure in the lungs. We usually start out about 5 centimeters of water, which in 90% of cases is not detrimental. I know we're talking a lot about interthoracic pressure, but 5 centimeters of water is probably not detrimental. When you get above that, you start worrying about some things. When you get above 10, you really start worrying. Although in some cases, you will see PEEP levels significantly higher than that. A Pmax is the Pmax and P minimum. Pmax is your maximum airway pressure. So if you go above that, it will actually blow off. It has like a relief valve on many vents. If you go beneath that, your minimum airway pressure, you can actually set on some vents so that you always have at least a minimum push to the breath that you're giving in. ACV and SIMV, these are ventilator modes. Apnea time. This is the time, you'll see this especially with vents that also do CPAP or BiPAP. This is the time which you'll click over from CPAP or BiPAP to a backup ventilatory mode. Not all CPAP or BiPAP machines have this option, but most of the ones you encounter in the hospital will. Oh, let's see here. Trigger, we talked about that. Tidal volume is VT. VTE is exhaled tidal volume. You guys get the idea. Let's talk a little bit note about tidal volume. When I first started this, we usually based off a rough weight, what we called, it'd be cc's per kilogram. And actually, it used to be 8 to 10, sometimes even 12 cc's per kilogram. What we know in the past 20, 30, 40 years, that those are very, very high volumes, especially for obese patients. Because just because we are carrying around extra 20, 30, 40, 50, 100 pounds, depending on how obese we might be, does not mean our lungs are any bigger. Our lungs are constricted by our thoracic cavity or rib cage. They remain the same size regardless of whether we are 150 pounds or 350 pounds. What does change the size of our lungs is actually our height. So what we do is we base our tidal volume off of predicted ideal body weight, not actual body weight, and we come to predicted ideal body weight based off of height, not scale measurements. Does that make sense? So when you look at a lot of charts, you'll find, kind of curiously enough, they'll have predicted ideal body weight, but they also have a height right beside them. And it differs from male versus female. And I don't know if I can, you see right here, here's a female chart, here's a male chart. This is from Ada County. You have height right here. You have a predicted ideal body weight. And then you have a tidal volume range between 4 and 6 milliliters per kilogram of predicted ideal body weight. We still do actual body weight for young kids, just the way it is, because it's hard to base off of height. You will see that question, by the way, in some form or another later on, so make note of it. Tidal volume is based off predicted ideal body weight, which is then estimated based off of height. So why do we put patients on mechanical ventilation, not intubation, but why mechanical ventilation? Well, we want to really control, we want to control the air that goes in and out so we can titrate it and adjust it so that we can maximize their PaO2, decrease their PCO2, but not maximize their PO2 too much and not decrease their PaCO2 too much. Other goals that are really important is minimize risk of lung injury. Bag valve mask ventilation that's done manually is very inconsistent. We tend to overventilate at too fast a rate, at too high a pressure, and give enough time that will be damaging to the lungs. Also, sometimes by placing them on respiratory support, we decrease their work of breathing because we're doing it for them. It's more comfortable for them while they recover from whatever critical illness, often in a semi-comatose or sedated state. So how important is it that they be on a ventilator? Well, if you work for Ada County, this is in our protocol that all advanced airways should have mechanical ventilation put on them as appropriate, or a reason documented why. It should be, and this is true both for ET and SGA. Now, what's our compliance rate with that? I'll be quite honest, I don't know. I know that it's probably not as high as I wish it was. You know, we can do some verbal gymnastics and justify a lot of things. But honestly, if you have the manpower, or especially if you don't have the manpower, you should probably get them on a vent sooner or later. The patient's going to do better for it. And I'm not picking on firemen when I say this, because paramedics are just as bad as this also. But you can watch respiratory rates climb, especially when we don't have end-tidal CO2 on at particular moments, simply because we don't have some sort of feedback telling us to slow down or pick up our respiratory rate. And usually we go way too fast. I've seen documented cases in some cases up to 40 breaths a minute, which, of course, if you ask the person doing it, oh, no, I'm not breathing this fast. Yeah, you are. I'm watching you. So a mechanical ventilator takes that guesswork out of it. It'll breathe. It'll do exactly what you tell it to, as often as you tell it to do it, in the way that you tell it to do that. Now, there are two types of ventilation. There is both positive and negative pressure ventilation. How do we, somebody from Idaho Falls, if you take a breath in and out right now, do you breathe by positive pressure or negative pressure ventilation?
Negative pressure.
That's right. But when we ventilate them with a BVM, we ventilate them with
Positive pressure.
Positive pressure. So just contemplate that for a second. And if you contemplate that we are breathing in what is fundamentally the mirror opposite of the way we're designed to breathe, you can understand how mechanical ventilation can be very traumatic physiologically to the patient, and therefore why patients suffer ventilator-associated lung injury and ventilator-associated ARDS and barotrauma, volume trauma, and stuff like that. We're not designed to breathe by positive pressure. It's just that's the way most of these patients get ventilated. Now, other indications are mechanical ventilation is indicated when a patient cannot maintain spontaneous ventilation to provide for their needs. Remember, ventilation includes oxygenation and ventilation removal of CO2. So when we look at indications of acute respiratory failure, these are not all inclusive, but if you have a pH less than 7.3, that might be an indication. PaCO2 greater than 55. This is one, I want to point this one out. End-tidal CO2 greater than 55 despite intervention. End-tidal CO2 greater than 55 despite intervention. So maybe you've nabbed them, you've got an oxygen going on in place. They're tachypnic, they're short of breath. You got the end-tidal nasal cannula on, and you're debating on whether you need to RSI them or not. This is not your only indication for RSI. But if you have this going along with, how you're going to describe the work of breathing, this is a number you can hang your hat on that if their end-tidal CO2 is greater than 55, despite other interventions, you know that you got something to justify your clinical pathway there. All right, so PaO2 less than 40. We already talked about oxygen desaturation curve. SpO2 less than 75% despite interventions. These are numbers that do not stand alone, but again can help you justify on paper and to your medical director why you maybe RSI'd someone, or why you did put them on CPAP, or a number of different things. Some other cases: shock, head injury, smoke inhalations, pulmonary cleaning and lavage, which you may get a chance to see that in the, well, are you guys still going down to Salt Lake to the burn unit, or is that shut down right now?
Idaho Falls is now a burn unit.
Okay, so if you're at Idaho Falls, you may actually see some pulmonary cleaning and lavage of patients with lower thermal airway issues. It's nasty. Any reasons not to mechanically ventilate? Well, absolutely is an untreated pneumothorax. You think, wait a minute, we intubate pneumothoraxes all the time. Yeah, but we also treat them. Now, treat them means, of course, chest tubes or needle chest decompression or so on and so forth. Now, that treatment may occur simultaneously with your intubation and putting them on a ventilator, but it has to be part of it. Some relative contraindications. Well, if the patient or family's informed wishes, i.e. DNRs. The risk versus benefit, medical futility, increased pain and suffering. Now, these last two are decisions that we normally do not have to wrestle with as paramedics, but you'll see people wrestle with them in your ICU rotations and other rotations. So you'll notice that we had a lot of different things, indications thrown up there. And it's really kind of important to separate, some of those indications are for respiratory protection, respiratory failure. Some of them are for airway protection and failure, and airway failure. Some of those are for anticipated clinical course. And that's an expression you see in our own protocols, where they don't necessarily need it right now, but they are going to need intubation and mechanical ventilation soon. And it's safer for the patient to do it on our timeline than when they are critically desaturating. So sometimes you'll see that as well. Are there any questions before we move on? Okay. So we talked about both positive and negative pressure ventilation. And I want to spend a few minutes talking about negative pressure ventilation. There are actually patients still in iron lungs. I checked last year, and there were about 25 to 30 still in the United States. Maybe a few more scattered in other places. I don't know. I couldn't find any hard data, but that's still are ventilated based on negative pressure. Now, some of them just at night, some of them throughout the course of their day and their entire lives. This is very similar to some patients who have tracheostomies and are on ventilators at night to assist with their respirations, but during the day, they're tooling around, doing whatever they have to do, maybe with some CPAP support, BiPAP support, or nothing at all. Christopher Reeves was that way, for those guys who know who Christopher Reeves was after his neck injury. Anybody know who Christopher Reeves was other than MK? Superman, right? Yep, broke his neck during a horseback riding accident. Yep. So this gentleman, incidentally, made the news probably about 4 years ago. His iron lung, that negative pressure ventilator right there. He was a lawyer, a patent lawyer, a very successful patent lawyer, but he elected to never get a trach. He actually ventilated and breathed by negative pressure. He was a victim of the polio epidemic. Stand by one, guys. Let me find my little deal here. My daughter poked her head in, and then when I turned around to see what she needed, she just never responded back. Okay. They used to have an iron lung at BSU. I couldn't get in it. It freaked me out. That's MK saying there. How long ago was that? Do you know? Or do you mind telling us?
So that was 96, 97,
Okay.
98.
Was that just for demonstration for the RT program, or I would assume?
I don't know. It's weird because it was in the kinesiology building.
Huh.
It was in one of the rooms in the old gym there across from the extra mile arena.
Maybe it's for their physical therapy. So they can do physical therapy inside of it, with a patient, because you can see there's holes or not holes, but ports in which you can reach in and do physical therapy or to do things, care on the patient.
Yeah, that's exactly what it looked like, was that picture on the right.
Okay. Now, so why negative pressure? Well, a little bit of history. This is what we use. The United States and other industrialized countries were filled with these. What is this from? Anybody? What would put so many people in negative pressure ventilators?
Polio.
Polio, which was nearly eradicated or greatly reduced in the 1950s, in a span of just a couple years, the polio vaccine. But before that, COVID, I hope not. But before that, literally every summer was polio season. And every time a kid got, not necessarily the sniffles, but got a little weakness in their legs, whatever, because it had a paralytic component to it, you read some of the diaries and some of the other historical anthropologic research from the era. This terrified people, especially since kids seem to be quite a bit more susceptible. And sometimes these people would be put in these ventilators for a few weeks. Not everybody caught polio would go into respiratory failure, but a few weeks till they could get over the hump of the virus, so to speak. And sometimes they'd have lasting paralysis in their legs and lower extremities, sometimes not. But this was a polio ward, and each of these are iron lungs, and they function by negative pressure. And you can't quite tell, but the one on the previous slide, the way these work is there's actually like a bladder at the end of this yellow one, that there's a machine that pulls that out and produces a relative negative pressure, and that reduces the work of breathing enough that they can breathe on their own. Physiologically, this is much less traumatic. These patients didn't develop ARDS. These patients didn't have a lot of the complications that we have with modern mechanical ventilators. And don't get me wrong, they still had plenty of problems, because of polio. But physiologically, this is actually respiratory mechanical ventilation that is more representative of the way we breathe. Here's another example of a large, huge iron lung. Here's another example. Can I get the idea of how long this was? Because you see the type of TV there. It's not a flat screen. I'd be terrified it'd fall on me. But anyway. Now, this is also interesting because of the polio epidemic in 1952. And I want to say that the polio vaccine was developed in like 53, 54. But in a town in Denmark, Copenhagen, they had close to 300 polio patients develop respiratory paralysis within just 3 to 4 weeks. Think about that. 300 respiratory patients, respiratory paralysis in a very short time span. This was before the age of anything resembling ventilators. So they developed, really just cobbled together out of hardware, this soda lime filtration. So gas would come. Let me get my little oxygen and nitrogen. So basically nitrous very similar to what we breathe in. A humidifier would come in, go through this soda lime, which would act as a CO2 filter, because when they breathe out, the one-way valve, they breathe out this way, and then this would capture the CO2 and they would bag. So this was all entirely a closed system. This is different than the systems now that have an exhalation port. Does that make sense? And you can see there, they're bagging with this, a patient with a tracheostomy. Now, what they had to do, though, is they had 300 of these patients. So they had to improvise this. They actually had all the local medical students. And when they pulling 24-hour shifts, because there were no mechanical time cycled, volume cycled ventilators. All these patients were ventilated mandatory for about 3 to 4 weeks. Because they didn't have enough iron lungs for all these. And when these 200 medical students were exhausted, they then hit up the dental students to help work shifts. And then they held classes for lay people to come in and help ventilate these patients. And they did this, and it was groundbreaking. Now, the impact of this on you guys, think, okay, great, this is interesting, but why is this important? The impact on this is this event directly led to the construction of the first commercially available mechanical ventilators, positive pressure ventilation. Now, when we look at positive pressure ventilation, it's just basically like a billows. We're pushing air in and out. The only difference is mechanical ventilation can control all the various little aspects of that function. As I said, it gives gas under positive pressure during the inspiratory phase. Exhalation is passive. Exhalation is passive. There are two types of positive pressure ventilation. You'll hear this referred to: non-invasive mechanical ventilation and invasive mechanical ventilation. When I'm talking about non-invasive mechanical ventilation, what am I talking about? Somebody from Idaho Falls.
Using like a BVM or something and not a advanced airway.
Bingo, exactly. And therefore, somebody from Meridian, since they did the heavy lifting for you, what would be invasive ventilation?
Intubation.
Yeah, intubation, or an LMA, or an iGel, or a King, or a PTL, or an EOA, or an EGTA. Have I missed any? Those are the ones I've personally used over my time. So I'm sure there's a couple other ones out there. So we look at non-invasive ventilation. This is still used. Matter of fact, up until recently, they would actually, I mean, I want to say recently, but there's still cases in which an anesthesiologist will practice the optimal face mask seal and may ventilate a patient non-invasively with good airway positioning, ear to sternal notch, head elevated, without an advanced airway in place for an extended period of time. And in the 70s and 80s, you did this before you ever got a chance to pick up a laryngoscope as an anesthesiologist or a paramedic. When I did my OR rotations, I probably spent an hour or 2 hours proving to the anesthesiologist that I could get a good face mask seal before he let me anywhere near laryngoscope blade. So if you guys are fortunate enough to ever go in the OR in your rotations, then go ahead and make sure you got that part down. And remember, that face mask seal is not just pushing it down the face, it's lifting the jaw up, jaw thrust, ear to sternal notch, triple axis alignment, the whole kit caboodle. I got a question here. I'm sorry, guys, I missed this question. Do I think iron lungs will make a comeback since they're less invasive when compared to a ventilator? Oh, yes and no. I think negative pressure ventilation might. I don't have a picture of it on here, but I don't necessarily think that actual iron lungs, those big contraptions, will. There's actually a device that is both CPAP, and I think it can also ventilate through negative pressure. I have to look it up. It looks like, honestly, it looks like a 1950s space helmet. You know, that big dome looking, you know, hello, my name is Marvin from Mars, you know, type of thing. And I'll see if I can't show a picture of it before we're done. It's pretty bizarre looking. but they are made in Texas now, and there's a lot of organizations that are using those to ventilate and to do CPAP for patients in a way that's safe for the providers and non-invasive for the patient. They're really common over in Europe. Let's see, we already talked about most of that. So non-invasive ventilation technically includes CPAP and BiPAP, even though these aren't actually, you're actually providing ventilation yet. But most in-hospital machines that provide CPAP and BiPAP also are ventilators. It's really only in the pre-hospital world you ever see devices that are separate. I'm not really sure why they do that. Seems like they could come up with a vest type contraption. Actually, they did. So MK made a comment. Seems like they can come up with a vest type contraption. There is a negative pressure vest that that was a lot lighter and more portable than a full iron lung. And I got pictures of it from the 1950s of driving in a car with it. But with the polio vaccine, the need for that just pretty much dried up. But remind me and I'll get it to you. So incidentally, this little baby right here is getting CPAP. This little baby is my daughter. She was about an hour after she was born. This is right before she was actually intubated because she didn't tolerate this very well. It wasn't providing enough support for her. But she was about 10 weeks premature at that point. So we talk about CPAP. We're going. Yep, just a little humor there. She looks like me. Oh Lord, pissed off. That's what she looks like. Let's talk about invasive positive pressure ventilation. And yes, I know this. I deliberately put this picture up here. What's wrong with this picture?
That is a suction.
Yeah, that is. Yep. You know, I could probably make $1 million being a medical consultant for some of these shows, like these soap operas, or was that Rescue 911 or Lone Star 911, whatever it is. Yep. So basically, invasive positive pressure ventilation is very much like non-invasive. One key point, and this is very important, is that since you're using an advanced airway, I said it before, but I really want to drive this in, what you have is, in essence, a closed circuit. So once you go to a closed circuit, then we really start worried about air trapping and retained interthoracic pressure and stuff along those lines. You can get that if you maintain a face mask seal for a long enough time, but usually there's some air leakage or adjustment, and then you have your passive exhalation. Let's get into the mechanical ventilators themselves. Whenever you hear somebody talk about a ventilator, it's classified according to how the inspiratory phase ends, and you'll see that again later. So it could be a volume cycled. In other words, the respiratory cycle ends, or the inspiratory cycle ends when you reach a certain volume, like a tidal volume or a minute volume. The pressure cycled ventilators end when your peak airway pressure reaches a certain level. Time cycled ventilators, this inspiratory phase ends at a set period of inspiration. Most machines can work in multiple different modes. You can switch them back and forth. But if you hear somebody talk about a ventilator in the hospital, most of them are pressure and volume cycle. Now, generally speaking, you could probably lump most ventilators into three general categories. There are gas-powered ventilators, which purely work off of the pressure of the gas in the line from the tank or wherever the oxygen source or gas source is. They generally are more dependent on your line pressure, so they need a minimum of 50 psi, some of them more. And they tend to be a lot more wasteful in your gas supply because they use part of that gas supply to cycle the valves and cycle the turbines and the aspirators and everything else that they do to do what they do. Electrically powered ventilators are a lot more precise. They have many different modes of operation. They frequently will come with a compressor, although some of them do not. And they allow more titration of your inspired oxygen. By the way, I forgot to mention FiO2. Anybody know what FiO2 stands for? I should have mentioned this. I'm sure it was on that list of all the different abbreviations. FiO2.
Fraction of inspired oxygen.
Yep. So somebody from somebody else tell me what that, translate that into Captain Dummy talk.
Is it something about how close to the ambient air it is, like as far as percentage of oxygen in what they're doing?
Not close to ambient air. It's just strictly a percentage of oxygen. So we'll say that it's a fraction. So 1.0 is 100%. Right? Everybody got that basic math down? 1.0 equals 100%. So 0.80 equals 80%. So if somebody has an FiO2 of 0.8, what percentage of oxygen are they getting? Idaho Falls.
80%.
80%. Boom, you got it. You will see that a lot of times. Now, a frequent goal is within the first 24 hours of a patient being on a ventilator. They want to get that FiO2 as close to room air as possible, if the patient will tolerate it based on whatever their illness is. And sometimes they tolerate it very well. So you'll have patients on 25, 30% FiO2, and they're doing fine for weeks on end. What we know is that FiO2 is greater than 0.5 or 50% for more than 24 hours, have a very high incidence of ARDS and ventilator-associated lung injury. You also find some ventilators that are electrically controlled but gas powered. These are the ones we have at Ada County. So they will not run without a oxygen source, or a gas source, I should say. But they have electronically controlled components in them to control the valves and aspirators and everything. So the gas really, it's a lot more frugal in your oxygen supply. Has a lot more options for modes, but it's still dependent on your line pressure. When I say line pressure, what am I talking about? Anybody?
The amount of pressure of oxygen in the line.
Yeah, in your O2 line, that green line that's coming from your tank or your gas source to the actual ventilator, or a white line if you depend on where your ventilator is made. Yeah, it's your PSI. That's exactly it. So this is different than liters per minute. Liters per minute. Most your gas supply in the hospital is between 150 and 100 PSI. In the ambulance, we had to turn ours up to support our ventilators because they were at 48 to 50. We had to turn them up to 60. But when you actually put the regulator on it, down, I don't know, down regulates that to and converts it to liters per minute, but is much shallower pressure. You guys ever hear of a demand valve? An elder valve is sometimes called it.
Yes.
How about you guys over in Idaho Falls? Is anybody still carry them on their ambulances?
It doesn't sound familiar to me.
Okay. So
we did talk about them in class like last week, I think. It has the button that you push when
Yep. So the very early ones weren't flow restricted. So if your tank was at 50 PSI, 60 PSI, whatever it was, in your line pressure, that's what the patient got their inspiratory breath at. Shortly thereafter, the FDA realized that was probably causing some pneumothoraxes, and they were supposed to be regulated to 40 PSI or less, regardless whatever's in the line pressure. But that's still a hell of a lot of inspiratory breath. And the bad thing about those is that most of them didn't have a pop-off or pressure relief valve, so you could pump as much air as their thoracic cavity could hold, whether their lungs could hold it or not. Okay, so we talked about volume cycled, pressure cycled, and time cycled ventilation. You may see that again later. Sometimes ventilators are kind of referred to by their main roles. So there's something called an automatic transport ventilator, and these are most common in the pre-hospital world. Now, I will say that there's a huge variability in these. So some are actually pretty decent ventilators. They're still not ICU quality, but they're still pretty decent. And there's some that are downright dangerous and everything in between. And I understand that you guys carry the auto vent and auto fall, so I don't want you to think about I'm picking on you, but I'm going to pick on the auto vent as being in the more dangerous sector. So you have conventional ventilators that are more capable of producing respiratory patterns that mimic the way we breathe. Most automatic transport ventilators are volume cycled. Now there are high frequency ventilators. Now these are specialty ventilators, and these will give extremely high cycle of breaths, very short, very brief, high pressure in and out with low tidal volumes. So as I put there, think about panting in dogs, how dogs pant and how quickly they pant when they're hot. They are in essence doing high frequency ventilation. So there are ventilators that mimic that. You might want to take, and these you will almost only see in critical care, specialty care, and ICUs. Why would we have high frequency ventilators where you're breathing so fast that you never really fully exhale?
So I kind of know this because of my roommate's kid. He had bilateral pneumonia and almost died, and both sides of his lungs were completely consolidated. So they put him on a high frequency ventilator to force that air as far down into his lungs as possible.
That is a pretty decent representation. So what they're also scared of is that they ever have a full exhalation or, a normal exhalatory cycle, that those lungs will completely collapse and we won't be able to get them open again.
Yeah, that he would completely collapse and die.
Yeah. So if you're in the ICU, and honestly with COVID, you may see this, but these are high-end ventilators and there aren't a lot of them out there. You also see this used a lot with neonates, which is kind of scary. So there are some conventional ventilators that, or let me back up. There are some high frequency ventilators that will also do conventional ventilation, but not a lot. So when you are in your ICU rotations, you will hear talk about the circuit and doing circuit changes and cleanings. The circuit is the plastic semi-disposable tubing that runs from the ventilator to the patient. Now, these are both simple and complex. So you'll see, like, here's one. You will have a water chamber to collect water to humidify, a collection chamber to collect condensation and runoff, so on and so forth. Here's one that actually has an inspiratory valve and an exhalation port with a HEPA filter on it. You also, this is an example of a closed circuit system. Like this is actually the one we have at Ada County. Here's a more generic one that actually has PEEP on that, as opposed to PEEP as part of the ventilatory circuit, or sorry, the ventilator itself. I will point out that you should be aware that these two devices look very similar, but they're not the same. This is an HME unit. This is, if you remember, we talked about tracheostomies. We talked about the artificial nose, where it had tissue paper in it, and it essentially just allowed humidification back and forth. You will see these sometimes in use. This is actually a HEPA filter, bacterial filter. And we have, ours look a lot different. Ours look more like this one, but this is actually so that when they are breathing out, whatever junk they're breathing out, it catches the virus, it catches the bacteria, so you don't contaminate the whole room. Right now with COVID, you'll see, and honestly in ICUs, these have been standard practice for about 10, 15 years.
Yeah, so our protocol now at gym is whenever we bring a code for somebody, we have to put the HEPA filter on because they are assuming that they are going into cardiac arrest due to COVID.
Yep, and that's our policy also. I can't tell you how much people are remembering to do it. the ideal place to put your HEPA filter is on your exhalation port, but I've seen it put on both the exhalation port and inhalation port between the BVM and the mask. So when you worry about ventilators, also worry about your gas supply, where it's coming from. Is it coming from the wall and your hospital has relatively decent oxygen supplies? May not be the case in some place like Brazil where they're running out of oxygen, literally. But if you're on an ambulance, you need to know, okay, what's your estimated flow rate? How long do you have? What's your buffer? So let me give you an example. Remember I talked about minute volume? If you know you're going to be using 5,000 cc's or 5 liters a minute, this is where, and a lot of times critical care services will have a chart, and you know you have so many liters in a tank, then you need to think, okay, well, if I have so many liters in a tank and my tank is half full, do I have enough liters to get me from point A to point B, assuming I also have a buffer? And if you don't, what are you going to do about it? What's your backup plan? Does that make sense?
Yes.
Yeah, especially for like Idaho Falls, where you guys do transports to Salt Lake, and I guess you guys still probably come up to Boise every now and then, maybe. Magic Valley does. I see them all the time. All right, so let's talk about some ventilation parameters, how ventilators operate. The biggest one is ventilator mode, and the ventilator mode is how the patient triggers ventilations. These are all different types of ventilator modes. Now, we're not going to hit all of these. We're just going to hit the simple ones. Where am I at on time? Okay, we're at 1400 hours straight up. Before we get into this, I want to take about a 10-minute break. And I admit I'm really bad about taking breaks, so just don't be afraid to remind me of it. But let's take a 10-minute break. We'll come back at 17 after. Greetings, everyone. Get you all get settled back in.
Welcome back.
Yep. Hope everybody had a chance to hit the head and they didn't break anything when they hit it. But no, okay.
You might have to tell the non-military people what the head is.
The latrine, the bathroom, the water closet. Yeah. Nope, just stepped on dog bone. Okay. Let me get this back up here. So let me ask you, are there any questions about what we've got? Somebody asked me a question before we proceed. I'd like to have a couple questions from one for Idaho Falls and one from Meridian on the stuff we've gone over so far.
Steve, I have a question.
Yes, ma'am.
So doing interfacility transports, I have done a lot of vent transports, and a lot of the times RTs will say patients don't tolerate certain vents. Can you explain why it's an equipment that they're not tolerating rather than vent settings when we match the vent settings?
It may be that your vent settings are not capable of matching what they have it at. Sometimes we have to approximate. That would be my biggest guess. Certainly, when you get to the level of critical care ventilators, there are some subtle differences between vents. But I think the biggest thing is that, like, our transport ventilators may not be able to do pressure support, as an example, and pressure support is a very big thing right now. That'd be my guess, because matching vent settings is more than just simply tidal volume, minute volume, and such. It also may be, I know that, when you get into some of the respiratory mechanics and physics and physiology, the way that the vents sometimes change between their cycles goes into it. And I'll be honest, that's a little bit beyond my understanding of ventilator mechanics, but I know that there are some guys that really geek out on that, and it's a big deal to them. Does that answer your question?
Yeah, thank you.
Okay.
Hey, Steve, I'm curious about the vents we carry at Ada County.
Mm-hmm.
If we were to pick up a patient that was on a ventilator at home, would we be able to switch them over to our vents? I mean, was that the purpose behind buying it, to have those different modes?
No, the reason we purchased it was to provide better ventilation post-ROSC, and for our side patients, the other things are just a bonus. Now, if I had a patient who's on a ventilator at home and I could keep him on that ventilator for the transport with the same settings that he was used to, and it was working, and that's the big thing, and it was working the way it's supposed to, I would keep him on that vent. So many patients who have vents, even if they mobile or whatever, they have transport bags. A lot of times they'll even have a backup vent. But these vents frequently will have batteries for power failures. Now, depending on how well the vent's maintained, how old it is, the battery may or may not be all that effective. But we do have inverters on our rigs. That would be my go-to. Because if that's the vent settings are working for the patient and the vent's working correctly and it's not a vent related issue, I would keep them on the vent, on their vent if possible.
Okay, so the other settings are just merely bonus material.
Yeah, for lack of a better term.
Okay.
Yep. So yeah, you're talking about like SimV?
Yeah.
Yeah. So there's no let me back up. I personally, let me stress my personal opinion is there's no reason why paramedics shouldn't do SimV, and in most states they can. But when the MSAC, or the Idaho Physicians Commission, wrote the specific statutes regarding ventilators in Idaho, they were trying to solve a problem with a particular organization or agency. And and the results of them, like with many things, when you try to use a hammer to solve a small problem, you end up screwing a lot of other things up. And the result is they wrote the legislation so that we weren't supposed to transport patients on ZimV, because they didn't want, this one agency doing critical care transport. That's my personal opinion. With auto vents. And then the result is that other agencies that had better vents than that, kind of got screwed. Personal opinion.
Gotcha.
There's a lot more to it, and I'm not going to mention the agency. I'm not going to mention the people that were involved. So don't get me in trouble there. All right. Oh, by the way, just so that I'm just going to put this up here real quick. Let me share my screen. This is that Martian helmet looking non-invasive CPAP / ventilator that you will see. Everybody see that right there? And that actual one, I believe, and the one right here is actually made in Texas, I believe. But this is, you see, there's other variations on that theme. It can do bi-level and CPAP. And sure, vest. See if I can find. Yep. Oh yeah. So here you can see images of negative pressure vest ventilation. And actually you can see people who are, I guess it's still in use. Can y'all see this on my screen?
Yeah, those people look way too excited. That little kid looks way too excited to have that on.
I'm pretty sure he's a paid actor.
I may be wrong, but I think my friend who has cystic fibrosis has one of those vests.
Possibly. They could. I do know that this is very similar, or maybe it also has the same function as the percussion vest, which they will use in cystic fibrosis. So it might be the same device. It might just be a similar device. So percussion vest, in essence, will provide high frequency percussive vibrations to the chest to loosen up the enhanced secretions that patients with cystic fibrosis suffer from, so they'd be coughed out and secreted and expelled. Does that make sense? So it may have that function, it may not. I know that the device that they use to do that is very similar to this. So
okay, that makes sense. And
yeah.
I have
and it may she may have both. So I don't want to speak for her. So yeah, go ahead.
What's up with the AR-14? Is it a real gun?
Oh, I just put my little if anybody wants a great channel, this guy on Forgotten Weapons, he's a museum curator, and every week or so he picks up from the auction house some obscure firearm and gives the history on it, and it's just fascinating. So I didn't get all the way through it. Okay, oops. All right. Oh, I got something in chat. Let's see what we got there. Oh, those look fun. Yep. Okay. All right. So let me stop share. Let me reshare. Okay, so like I said, there's a whole bunch of different ventilation modes, and sometimes these actually overlap a lot, and there's a lot more than what we've even what I have up here, but these are just some of the more common ones. Something that you don't see very often is CMV, or controlled mandatory ventilation. The old auto vent 1000s were CMVs. Basically, a CMV is a automatic BVM. And that's pretty much it. Assist control ventilation is CMV with some assist for extra spontaneous breaths. Intermittent mandatory ventilation is pretty much what it sounds like. And SIMV, synchronized intermittent mandatory ventilation, is basically where we'll try to time some of the intermittent breaths with the breaths that the patient takes. We've already talked about CPAP, BiPAP. some other ones, APRV, high frequency ventilations, pressure regulated volume control. These are much more complex, and we aren't going to hit a lot. We're not going to talk about it a lot today, but just understand that there's a whole world of respiratory mechanics and ventilation beyond just what we see on the ambulance and what we're going to talk about. So we talk about controlled mandatory ventilation. I like to call this thing the Terminator because it will not stop. It will keep breathing for the patient until it kills them. And we joke about that, but and this is the old auto vent. Oh, that's actually the 2000. The 1000 was even worse. I think you guys have the 3000 now, which is a little bit better. But you can see there's basically two functions on here. There's respiratory rate and tidal volume. Not necessarily a pop-off valve, or if there are pop-off feature. If there is, it's just preset. There's no ability for it to assist or compensate for spontaneous breaths. So the patient can try to take a spontaneous breath and they just simply will not get one, no matter how hard they try. This type of ventilator is best for patients who are completely paralyzed, who have no respiratory function, who are completely apneic, and who are very, very sedated. And that's sedation. When I say sedation, I don't just mean like not breathing. I mean sedated against the uncomfortableness of suffocating when you're trying to take a breath and you can't. So benzos, propofol, maybe some opioids for the discomfort as well, things of that nature. Now, every year I've taught this. I've heard from Idaho Falls, well, this is what we carry. I don't want you guys to feel like I'm picking on you at all. But when you talk about automatic transport ventilators, this meets the standard of having an automatic transport ventilator. But you can see it is very limited in function. Now, assist-controlled ventilation, ACV, is basically identical to controlled mandatory ventilation, CMV, with the exception of the patient can take a breath. Now, when they take a breath, here's the downside. If they're breathing 5,000, a minute volume of 5,000, so our 10 breaths a minute, 500 cc's per breath. And then in between one breath and another, they try to take a breath in between and they trigger it, they still get that 500 cc's of volume. So that 5,000 cc's per minute suddenly became 5,500, which may not be a big deal, but it's pretty uncomfortable for the patient. And maybe they didn't need that extra oomph, but they got it whether they wanted it or not. Does that make sense?
Yes, it does.
Okay, so you might see a question, hint, hint, where I give you all these different parameters. You know, patient set on this tidal volume, patient set at this minute volume, patient set at this respiratory rate, patient takes an additional breath, and XYZ happens. What ventilatory mode is this? And you may have to choose between pressure support, controlled mandatory ventilation, assist controlled ventilation, or CMV, or something along those lines. And if they can't take the breath, it's controlled mandatory ventilation. If they can take a breath but gives them the full 500 cc's, it's assist controlled ventilation. And if they can take a breath on their own and just take the extra air that they want without interrupting the respiratory cycle, then that's probably synchronized intermittent ventilation. So CMV is very much like ACV, except when they take that extra breath, they don't get an extra 500 cc gut punch to go along with it. It's more, it's not perfectly in tune with what the patient work of breathing is like. But for a patient that may have some respiratory effort, it allows them to take breaths as their comfort and as they physiologically want to, without being as traumatic. Does that make sense? And the good news is that depending on the amount of breaths and the volume they take, it will adjust to still meet their minute volume, but adjust their actual respiratory rate down. So it allows the patient to compensate some. Now, pressure support ventilation is really for patients who have spontaneous respiratory effort. The patient will initiate every breath, and the ventilator simply delivers the support. But their support is based on airway pressure, not necessarily a tidal volume, although they may have a minute volume cap or a minimum minute volume they're supposed to meet. Does that make sense? So the patient generally regulates, for the most part, their own respiratory and tidal volume, but depending on what other little features you have turned on and off, it may still ensure they get a minimum minute volume as well. That's pressure support ventilation. We already talked about PEEP. Most ventilator modes will have at least 5 centimeters of PEEP as their default. You can turn it down or add more. 5 centimeters of PEEP is usually perfect. So let's see if this plays for y'all. Can you guys see that just fine?
Yes.
Okay, so I want to start again. I want you to really pay attention to how the lungs just completely return to their normal shape and symmetry and collapse state.
So I have a quick question regarding that.
Yeah. Real
so
quick
we-
before you get to your question, I just want to point out, did you notice how when he opened up the circuit to atmosphere, how quickly those lungs deflated? Did everybody see that?
Yep.
Okay,
Yeah.
because that is exactly what I'm talking about. If you get air trapping, how effective just simply unplugging the vent for just 15 seconds, 10 seconds, and letting the patient exhale into atmosphere. Now, granted, these are fairly healthy lungs compared to probably some COPD lungs, but how effective it can be to release the pressure in the chest cavity. So I'm sorry, MK. I think that's MK. What can I answer your question for you now?
It's not MK, it's actually Kiera. But
Okay,
I
sorry.
was just curious if there's ever instances where our lungs are completely deflated like that. Like, would it be like that if we got rid of all of our residual pressure or residual?
If you got rid of
breath?
everything and you had completely nothing in there, yeah, but that's not the case. Now, we'll say that there's about 25 to 30% of
Okay.
alveoli in our lungs in between each breath that are not inflated every time. So I want to say again, about 25, 30% of alveoli in our lungs are not inflated at any given time. Now, if we want to improve oxygenation, sometimes what we can do is called alveolar recruitment. And that's what's one thing that PEEP helps, is it gets more alveoli into the business of oxygenating with each and every breath. Does that make sense?
Yes, it does. Thank you.
Yeah, so check this out to add a little extra element with this. So when we prone, you hear about them proning patients with COVID and with ARDS, right? Has anybody not heard of that phenomenon where we turn the patient prone or whatever the case may be? Okay. I'm going to assume everybody's heard of that. Idaho Falls, you all still with me?
Oh yeah, we're here.
Okay. And Meridian, y'all still here? Okay. So proning isn't simply turning them on their belly, because you have to allow their belly to expand, their chest to expand. So there's a specific way to do proning that allows for chest expansion. It's not simply rolling them on their belly. But they think that the reason why proning works is because it changes the way airflow flows into the lungs and it's a form of alveolar recruitment, where it allows different alveoli that previously were kind of on the border of atelectasis, that previously were somewhat consolidated, to pop open and get in the game of oxygenation. It's a transient, it's a bridge method to improve oxygenation. It may buy you a little bit of time, but it's not going to be a solution by any stretch. But y'all, that's an example of alveolar recruitment as well. Somebody asked, are those pig lungs from airway? I'm guessing those are pig lungs. Those are awful small to be bovine lungs. So I'm pretty sure those are pigs. And to be precise, I would say that is organic, grass-fed, free range, or free range isn't the right term, but not pen-kept pigs. And the reason is I've been at some slaughterhouses before, and you can tell the difference in the lungs who are kept in lots, the pigs who are kept in lots their whole lives, because they look a lot sicker than that. And the vet there actually showed me the difference between the two. And those look incredibly healthy, but they certainly don't look like they came from a lot, which will almost look like smoker's lungs. So anyway, yeah. All right, so replace one more time so you guys give a little image, so you, or better view, so you know what to look for. One other thing I want to point out, a lot of people aren't aware, just having a PEEP valve on your BVM will give you about 5 centimeters, 2 to 5 centimeters of PEEP. The only way if you have a PEEP valve on your exhalation port, the only way to get 0 PEEP is to actually physically take it off. So hope that's useful. Let's talk about CPAP. Y'all like that? I heard somebody go, wow, man. CPAP is used with spontaneous breathing patients. It does not provide ventilatory support. It decreases work of breathing. And it's a constant airway pressure. So it's the same airway pressure measured in centimeters of water. It's the same airway pressure whether they breathe in or they're breathing out against it. Now, the difference between this and PEEP is only providing extra airway pressure when you breathe out at the end of exhalation, at the very end of your exhalation cycle. I love you too.
Bye.
Bye. See you tomorrow. Yeah, pressure's same. PEEP is only during the end of your expiratory cycle, where this is constant pressure throughout, and it doesn't change. Now, it depends on that last little statement, typically no apnea backup. It depends on the device. If you're using a ventilator that has CPAP function, it will usually have an apnea backup, but you need to know that for sure. You need to know if it's turned on. That's where your apnea time comes in. Apnea time is the period it will allow no breath to occur before it kicks into whatever the backup mode is. In our ventilators at Ada County, it's 40 seconds, I believe, 20 or 40 seconds. If you have a disposable CPAP device, which a lot of agencies use, they don't have an apnea backup. So if the patient's sitting there and you're not an astute medic paying attention, they can be turning blue on CPAP. CPAP's working fine, but they're not breathing on their own. The way CPAP works is essentially stents open or splints open or distends provides extra air pressure and opens up the alveoli. We used to say that this pushed fluid across. It's not technically accurate with what actually happens, but what it does is it distends. Let me get my little laser pointer here. It distends the alveoli, which thins out the alveolar wall. And if the alveolar wall is thinned out, then gas exchange is easier. And I like to think of this like a balloon. Have you guys ever blown up a balloon to the point where you can almost see through it because it's stretched out? Well, you can almost see through it because it's becoming slightly more semi-porous and light is passing through. Alveoli are the same way. There's one cell layer thick, and the more they're distended, the bigger the gaps in between the cells in that cell layer are, and gas can transport back and forth easier. And because there's a positive airway gradient or a pressure gradient with gas, fluid is less likely to spill in, where gas is more easily to transport out into the pulmonary bed. Does that make sense?
Yes.
Okay. Anybody else? Because I love you to death, MK, and love you. That wasn't directed at you guys. That was directed at my daughter.
Okay, thank you.
You don't love us?
Time to go. No, but seriously, I want to get some more interaction from some of the other guys. I know that this is kind of difficult, and the way I have my screen set up, I'm not necessarily seeing everybody's face just right now. So, does anybody have any questions on the way CPAP works there?
I just want to make sure I understand exactly how it helps the fluid get across. You said it doesn't necessarily push it out, but it just makes it a thinner membrane so it can diffuse better.
Well, that's part of it. Now it depends on what that fluid is. So like lung butter, pneumonia, stuff like that is thicker. It's more viscous. It's not going to go, it has nowhere to go. But like actual plasma from CHF fluid, from the interstitial fluid leaking across, yeah, that will go back across. Because it gets distended and it goes into the interstitial spaces right around here. But to say it's actually pushed out is probably a misnomer. But you have your pulmonary capillary bed around it that you get better gas exchange. And because it's better gas exchange, because the alveoli are open, because when they take the breath in, because remember, we breathe by negative pressure. And so the negative, they're in the inspiratory phase with the extra CPAP, it actually, I wouldn't say assist, but it's easier to take that breath in. Then it decreases work of breathing. Does that make sense?
Yes. So is it correct to assume that a CPAP would improve lung compliance?
Lung compliance is a factor of elasticity and bronchial dilatation and your air passages.
Okay, so it doesn't really have to do with alveoli.
Well, it does. If your alveoli are going to expand and distend and everything, great. That's great lung compliance. But if there's something physiological that's preventing them from doing it, let's just scarring, COPD, so on and so forth, then they're going to have shitty compliance regardless. CPAP is still going to help, but it's not it's not going to change the structure of the lungs that have been damaged from 50 years of smoking. Does that make sense?
Yeah, it does.
Yeah.
Thank you.
Okay. I got a question. So is it two-pronged, pushing some fluid out and allow better diffusion? Yeah, that'd be a good way to describe it. It's multifactorial. Yeah, I would say that's accurate.
Our pressure setting, is that normally 5 centimeters of water?
So we start at 5, but you'll routinely see 5 to 10. Now, I'm going to point out, brings up a great point. You will frequently see, when you go on patients who have CPAP in their home, you'll see them up to 20 or 30. But usually when you see that on CPAP, they have a nasal CPAP. So it's not a closed circuit. So if they ever overpressurize, their mouth is open, right? So the excess pressure, it will self-relieve, almost like a physiological relief valve. The CPAP that we use in pre-hospital setting is a closed circuit because it's a face mask seal over both the mouth and nose. And therefore 20 to 30 cc's of centimeters of water pressure in that setting is much more dangerous. So at Ada County and most places in the pre-hospital setting, they usually cap you somewhere around 10 to 15.
Okay, that makes a lot of sense.
See, I did something that made sense today. Okay, on your Ada ventilators, when apnea happens at 40 seconds, does it switch to ventilator mode or an alarm? It does both. So on our ventilators at Ada County, if you're in CPAP mode, and I want to say it's at 20 seconds. It may not be a full 40 seconds, but don't quote me on that. It's been a while since I've looked at them. Whatever the threshold is, when if they don't take a breath, it will alarm and automatically switch to ACV and just start ventilating them. So it does both. So I hope that answers your question. So the question is, what is BiPAP? Now, interesting enough, we call everything BiPAP, just like we call most sodas Coke, right? Or Pepsi or Pop, depending on where you are. But actually, BiPAP is technically a proprietary term. And I don't remember if it's Draeger or which ventilator manufacturer actually has the copyright on that term. Everywhere else, they call it bilevel, but we all call it BiPAP. So the terms are nearly synonymous, or for all practical purposes, synonymous. Now it's similar to CPAP, but the device, which is usually a ventilator, is complex enough that can tell the difference between inspiration and exhalation, and will have two different levels for inspiratory positive airway pressure and expiratory positive airway pressure. So when you breathe in, it might be at 10 centimeters of water, and you breathe out, it might be at 5, or whatever it is they've adjusted it to. And it's probably important to note that you can actually have patients who are intubated who are on BiPAP as a trial before they actually get extubated. So you may see that that combined with pressure support in the ICU if they're about to get extubated in the next few days. These patients tend to do better long-term recovery. They tolerate it better. It appears to be a lot more comfortable. And when I first started, you only saw CPAP in the ER, but now you'll see bilevel or BiPAP in the ER all the time. There is a question on whether for like CHF or COPDers in the acute setting or it's in the emergency context, whether it's truly better than CPAP. But I think the literature is finally going to start showing that it is. So now, how long will that be before we do BiPAP in the field? Well, it depends on your vents. The vents are certainly out there for the pre-hospital setting that can do these. It depends on what your state statutes say. Little joke there. You might know what movie that's from, or am I dating myself?
Silence of the Lambs.
Yes. Silence of the Lambs. By the way, if you want a song that you cannot get out of your head, just look up The Greenskeepers and Lotion as a music video on your own time. It's just creepy. I wouldn't say it's not safe for work, but it's just creepy as hell. And it's a song inspired by Silence of the Lambs, and it's got a tune that just sticks in your brain. It's like an earworm in a bad way.
I was gonna say also Joe Dirt.
Oh yeah. Oh God. Okay. All right. So high frequency ventilation, there's 3 different modes I have up there. There's probably more variations thereof. Some of these rates go up to 60 to 100 breaths per minute at very low tidal volumes. Some of these up to 400 to 600 breaths a minute. That's called high frequency jet insufflation. So for all practical intents and purposes, the lungs are in a constant state of inflation to allow oxygenation and ventilation without ever actually allowing the lungs to deflate. And a high frequency oscillatory ventilation up to 4,000 practical breaths per minute. So these are used with neonates, ARDS, so on and so forth. A lot of times these are used with some kind of novel gases. Heliox has been used, oxygen nitrogen mixes, and probably some other gases I haven't even considered. You will usually not, you'll only see these in the ICU and on specialty transports, like maybe the maternal transport team, dedicated critical care units. These are very intensive. A lot of times these are managed by RTs or two or three, a multidisciplinary team with the RT managing this, or physician. Now that we're getting toward the end, you can see there's a lot of things we didn't discuss. A lot of things that we didn't discuss here. And we both because time and complexity, and you're just not going to see a lot of it. Here's something else that you may see. It's still done. I'm just going to point out because of COVID. This was actually my first interfacility transport as a paramedic in 1995. When I've got my first full-time paramedic job. They said, "Oh yeah, you can handle this transport. There's on a vent. You can handle it, right?" I'm like, "Sure." You'll take an art, yeah, well, sure. And they go, "By the way, it has two vents." I go, "What?" It's a bifurcated ET tube. So in essence, you have two different lumens, one for your right main stem, one for your left main stem by default, and you can ventilate each lung independently. You see right there. Yeah, that's fun times.
Why would you need to do that?
ARDS, COVID, severe pneumonias. Like I can't remember who it was who mentioned that their kid was on high frequency jet insufflation where their lungs were so consolidated they didn't want to deflate. So in this particular case, the one I had was actually a former partner of mine's wife, who is a horrible smoker and diabetic and just a clinical mess. But she had one lung that was completely consolidated and one lung that was still functioning somewhat normally. So they had one lung, the consolidated lung on high frequency jet insufflation, and one lung on normal ventilation. There are some other novel ideas out there, such as liquid ventilation has been done, not done anywhere around here. If you remember the movie Abyss, where they had these fluorocarbons or whatever they were that were used for deep submersion ventilation. Those are actually used in really high acuity respiratory patients. Not anywhere around here, but just a little novel idea. All right. Common complications from mechanical ventilation. We talked about this in the discussion boards. Let's see where we are in time. Okay, good. So I want to really point out something. When the ventilators we got, my former director basically decided that we're going to change vents for whatever reason. Goes, "Don't worry, they're foolproof. All you need to do is roll them out. Training simple." Is there such a thing, after everything we've gone through today, do you think there's such a thing as a vent that's just plug and play, ready to go?
No.
No, I don't. And I'm one. You may work for a new agency, you may go somewhere, somebody may say, "Oh yeah, they're simple. You just plug it in, turn it on, it does everything for you." No such thing. And while vents are sold that way, vendors will tell you that. I think if nothing else, if you have a healthy respect for how you can really kill, I want to stress this, if you don't pay attention to your vent, you can kill your patient. If you don't have a healthy appreciation for that, or correction, if you walk away with this class with just that, then that's a win-win. I don't want you to be afraid of the vent, but I want you to respect it. Because the problem is, a vent will do exactly what you tell it to do. Nothing more, nothing less. And if you tell it to do the wrong thing, because as they like to say, you play knobology instead of understanding what it is you're doing, just adjusting tidal volume and respiratory rate, then all sorts of bad things can happen. Sometimes the problem comes when a vent tries to do one thing and the patient is trying to do something different, completely different. So that's where your assessments and your understanding of the underlying pathology come in. So the other thing is that there's a big difference between what you set the vent at and what actually happens. So what you need to do is look at your settings and compare that with what you're seeing. Look at your settings and compare that with what you're actually seeing to see if it's doing what you're telling it to do. I'll give you a prime example. Anytime you put somebody on a vent, you should spend at least 10 seconds or more hooking the vent up to a test lung before you actually hook it up to the patient. We have test lungs in each of our vent bags. I don't know if you guys have them or not. They're really cheap. They're basically artificial. I don't even know how to describe what they look like. They look like sandwiches with a rubber band, and they got a little balloon in them, and they inflate and deflate, inflate and deflate. Because if you have it set at 500 cc's a minute at a tidal volume of, 500 cc's a breath at a tidal volume of 10 per minute, and suddenly it starts breathing really funny, like every other second, you know something's wrong. I use that exact example. I don't know, MK, if you've seen it, because we found our vents would do that in a certain set of circumstances if you took off one piece of the vent circuit tubing. Our vent circuit tubing has a 90-degree angle elbow at the very end of it. Looks like a nothing piece. Oh yeah, we don't need that. And you can hook an ET. If it falls off, you can hook an ET directly up to the vent. No big deal. But the vent is calibrated to sense the resistance at that 90-degree angle, just through the air pressure it sends down. If it doesn't sense that resistance, it goes into a diagnostic mode trying to find it. And that diagnostic mode has the unfortunate incidence of breathing 40 times a minute at about 300 to 400 cc's per breath. Would that kill a patient? 40 times a minute at 400 cc's a breath. Would that kill a patient, you think?
Pretty fast.
Yeah. Really fast. And you would only notice it if you put them on the test lung first, because it'd be really easy to miss in the chaos of a real scene. So, or if you can also notice it if you actually are observing your vent closely. But if you're not dialed in on this, it'd be really easy to miss. So that's why you need to not just set some settings and go on to whatever the next crisis is. You need to actually observe the vent, observe the patient, make sure the vent is doing what's supposed to be doing to the patient and to the test lung right before you hook it up. These are crucial, and it seems really simple, but if you forget this crucial step, sooner or later your vent will malfunction. There'll be something wrong, and then you'll be in a world of hurt.
So after testing the ventilator, make sure it's working properly, if you're doing like an interfacility transfer with someone with a ventilator, would you most likely just take the hospital settings that they're already using to ventilate the patient?
Yeah.
And plug that into yours?
Yeah. Yep. And depending on my comfort level of the vent, I may just keep them on the vent they're already on. But I'll be honest, when I first started, you saw a lot of LTV 1200s in the ER. You don't see those a lot anymore. They're pretty old. So what do you see now? You see Dragers, you see Hamiltons, and I'll be honest, it's been, well, since the early 2000s, I've done regular flight or anything regularly considered critical care. I wouldn't feel comfortable with those. Yeah. So, if I could, I would try to mimic the settings as much as I could. Yep, absolutely. And I would recruit the RT into helping me with that. There's no shame in these things. Even if it's for a 5-minute transport, a patient can rapidly deteriorate in 5 minutes if you don't have this done right. And the reason they can rapidly deteriorate is exactly what I have on the screen now, hemodynamic effects. And that's one of the questions from the discussion board, where you have increased intrathoracic pressure, reducing your preload, kicking up your afterload, which causes, which can actually cause some heart failure, which can actually cause your blood pressure to drop, your central venous pressure to drop. It can affect your renal system and your perfusion there. Actually has some pretty significant hemodynamic effects. So we want you to be dialed in on that, on the importance of getting these settings right. Cool. Something else, and you'll spend a lot of time with your RT rotations doing this, and that's monitoring cuff pressure. So ideally, in a perfect world, cuff pressure should be less than 20 centimeters of water. And what happens if your cuff is overinflated, I think I mentioned this, you'll actually get pressure sores and stenosis on the inside of the trachea. And this can happen because it's so moist and so well perfused in as little as 20 minutes. Yet they actually did some research and said, well, let's see what cuff pressures are in a pre-hospital setting. So they actually measured cuff pressures in patients, and they found that 84% had pressures above the recommended maximum, above 30 millimeters of mercury, or sorry, centimeters of water, 84%. Most of them had pressures in excess of 120 centimeters of water. Think about that. 120 centimeters of water. That's huge when we are shooting for 20 to get a good seal without compressing blood flow to the interior lining of the trachea. So I've been trying to get us to get cuff. These, they look like blood pressure cuff. They're very similar, but they're not. That you literally just hook it up to the pilot balloon of your ET tube or your LMA or whatever. It's all the same connection, and it'll give you a reading. And then you actually, as a stopcock valve, you can bleed off excess pressure to get you in the green. Does that make sense? Unfortunately, they're about $300 each, and it's been a hard sell for some reason, which is kind of silly. What is the pressure recommendation on ET package? I don't know if it has one. It has a CC recommendation, but I don't know if it has a pressure recommendation. I'd have to actually look at it.
What is the equivalent of CC for like the pressure to be at 30 centimeters of water?
It's not a because the CCs doesn't, it's not a set CC because it depends on the diameter of the trachea you stick it in. So a really large trachea with a really small tube, you may have to stick a full 10 cc's in to get a good seal, and you still only may be at 20 or 30 centimeters of water. ET tube that closely fits into a tight trachea, you may only need 3 cc's to do it. So it's not, there's not a linear relationship between the cc's you stick in and the pressure of the cuff. Now, what they did find in the same study is that paramedics really sucked at estimating cuff pressure, because we're always taught just see if the cuff is, the pilot balloon is distended. Well, we had no idea, and even RTs couldn't judge us accurately. So
the only real way to judge it accurately is have that device you talked about.
Correct. And they make some disposable ones now, I think, but I don't know how much they cost. I should look into that.
How much did you say that one costs?
These are about $300 each. And that was when I looked at it a couple years ago. It just says there are 150 for 10. Is that for the disposable ones that look like syringes? So Patrick, yeah. Okay, great. So going back up here to questions. So even the manufacturer recommended volume may result in increased pressures if the trachea is particularly small. Yes, that is accurate. Somebody asked, so why do we put 60 cc syringe in the airway bag? Because the manufacturer recommends up to 60 cc's for the LMA cuff, the size 5 or 6. Yeah, 5, the largest one. Or 40, I'm sorry, not 60, up to 45 cc's is what they recommend for that cuff. So that's why we have that syringe in there. All right, barotrauma, we talked about that. In essence, it's ventilating too hard, too fast. We're actually over time, so I'm just going to briefly hit on this. Ventilator-associated pneumonia. And we already talked about how subglottic suctioning and stuff like that. But in the pre-hospital setting, one thing that can really lead to this is poor procedural hygiene. Poor procedural hygiene. Now, I mentioned this extensively, or not extensively, I mentioned this last time, where if you have somebody you're intubated and you have the ET tube already and you pull out the package, you lay it on their chest because it's convenient, you've just contaminated that tube. So how do you reduce this? Well, one thing I do is I'll open up the package, lube the distal end of the cup of the tube and stick it back in there so it stays sterile. Keep it handy. I may hand that to somebody to hold for me while they're assisting me. So they just hand me the tube when I need it. I'll try my best to keep from drizzling it into cat hair and the vomit on the ground and the feces on the wall. But also understand that we are sometimes passing it through a mouth they just vomited and stuff like that. So there's only so much we can do. Biofilm is a term you'll hear, and biofilm is just the moisture that we breathe out every day. It will form a film on the inside of the ET tube, and that will actually become a haven for bacteria as well. And actually, especially for pediatrics, you can get so much biofilm, it can actually increase your airway pressures because you need to push air harder through it because it gets narrower, just like a smaller fire hose. And of course, you get air trapping that way. So that's why just suctioning that biofilm out can make a big difference. And basic hand hygiene. Whenever you're going to suction a patient or whatever in your RT rotations, and your RT should be pretty good about this, scrub the hell out of your hands each time, that type of thing. And you'll wear gloves and probably sterile gloves during it. We talked about subglottic suctioning already. And we talked about ventilator-induced lung injury causing overstretch, and that constant overstretch actually can promote barotrauma and value trauma as well. All right, so one final bit of troubleshooting. If you have a problem with your tube or with a patient on a ventilator, the first thing, and there are some people that disagree with this. Okay, so like Wingard from MCRIT disagrees with this, but he has an RT right there with all the resources he needs to solve his problem. And if you don't know who Scott Wingard is, he's a ER doc who's really big in critical care and emergency medicine. But I still believe that, this is my personal opinion, that the first thing you should do if you have a ventilator issue is take the patient and put them on the BVM while you troubleshoot the vent. Do not spend 5 minutes troubleshooting the vent while your patient desaturates. Now, what this means is you need to have the resources to do that. And part of that resources is have a BVM with a mask with the patient at all times. I want to stress this again, and you'll see this in a test. Have a BVM with a mask with the patient all the time. Now, why would you have a BVM without a mask with the patient? Anybody?
If perhaps they had a tracheostomy tube and you could just hook the BVM directly up to that.
Yeah. Well, yeah, that's exactly it. Or here's an example. You are working a code or for some reason you intubate a patient in the house. You are bagging them first. Picture this. You intubate them. The provider assisting you pulls off the mask, puts the BVM on there. Where's the mask go? It goes in all the trash with all the other stuff. It doesn't follow the patient to the ambulance, doesn't follow the patient to the ER. And then suddenly the patient gets extubated or needs to be extubated. And you have a choice between looking like an idiot or doing the nasty lip lock because the mask got left in the trash in the patient's residence with the captain cleaning it up. Does that make sense? So make sure that everywhere the patient goes, if you have an advanced airway and you have a BVM and you have a mask with you, because every so often bad things happen because you weren't prepared. The other thing is, if you are going to troubleshoot a vent, you need to have a second person with you to manage the simple things, such as bagging while you're troubleshooting it, doing compressions while you're troubleshooting it. So I'm a strong believer that at least in the pre-hospital and critical care setting, vent patients should have a second set of hands in the back. I know that that's not always a possibility depending on your agency, and I understand that. I'm not passing judgment, but especially in an emergency setting, if I'm putting someone on a vent, I'm taking a patient or a second provider with me. It doesn't necessarily have to be a paramedic if one's not available. I prefer it would, but all I need is somebody that can do compressions, do a BVM, and knows their way a little bit around what I'm doing, and I can manage the rest of it. That's the bare minimum of what I need. So that if I need to hand the BVM to somebody while I do something on my monitor, or I troubleshoot my IV pump, or I troubleshoot my pump or my vent, or I do whatever else like whiz bang paramedic stuff I got to do, I got somebody I can trust to squeeze a bag, monitor the airway while I do that. Now, here's one final thing. Beware of alarm fatigue. What is alarm fatigue? You will hear this term, alarm fatigue.
You know, you like no longer hear the alarm because you've heard it so often that you no longer hear it. It's not annoying to you anymore.
Yep. And I'll tell you, sometimes it's purposeful. You get tired of vents being annoying and you're like, oh, they always alarm. It's no big deal. And you don't address it. Every alarm that goes off on a vent has a meaning. And every time it goes off, even if it just went off a second ago, you've got to address it and look and see what it is. I know that's a pain in the ass on some of these vents, especially the vents we have at Ada County. They alarm, they're kind of sensitive all the time. But if you ignore it, that'll be the one time it kills your patient. I promise you. Just like if you say, oh, the entitled CO2 is not working on the Zoll, it never works on the Zoll, is the one time you have a gut tube. You have to pay attention. There's a reason why we hit these simple things over and over again with no tolerance for not. It's because when you ignore this stuff, patients die.
So what does the doctor believe you should do then while troubleshooting a ventilator?
So elaborate a little bit on your question.
You said he doesn't agree with.
Scott Weingart. Okay, yeah. So Scott Weingart believes that the patient should be kept on a vent because a vent does provide better ventilations, and it does. It does exactly what you tell it to do. But the one difference is he's doing it in a resuscitation bay with 3 or more nurses, probably another doc assisting him, and an RT to focus only on the vent to help him troubleshoot it. That's not our situation. Because he works in an ER, right? And he basically works in an ER that allows him to set up mini CCU units in his ER for his resus bay. So he's completely I wouldn't say over resourced, but his resource situation is different than ours. And he's able to cognitively offload and focus solely on the vent. That's not our situation. So I still believe that and I'm open to debate. I can be convinced otherwise. That if you have vent that's malfunctioning, put the patient on the BVM while you figure out what the problem is, because the problem may be important. Does that make sense?
Yes, it does.
Okay. And you guys don't have to agree with me on that. That's fine. But that's
piggyback off that. I've actually ran a call like that in a facility with our critical care team.
Mm-hmm.
We had our vent malfunction, and we just bagged them until we got RT back down to help us out.
Yep. And if you have a properly functioning vent and you've hooked it up and you've put the settings correctly for the patient's condition, a vent is superior to a BVM every time. But if the vent is malfunctioning, then it's not doing what you need to do. Transition them to a BVM just long enough to solve the problem, then consider putting them back on the vent. Finally, be kind, especially during transport. Paralyze, sedate, and give them analgesics or combination thereof. Ketamine, rocuronium, opioid of choice, benzo of choice, or some combination thereof. These patients should never be paralyzed without sedation. And please remember that. Never give a paralytic without something for their mental status. And I don't mean just a drizzle of something. I mean a lot of something for their mental status. Now, frequently, if you're doing longer transports, you will find that starts to wear off. Rocuronium lasts about 20 to 40 minutes. Versed, roughly the same. Depending on how much fentanyl you give, roughly the same. Morphine a little bit longer, but it's not as big of a hammer. Propofol is on and off within 5 minutes of initiation. So how do you know if you need to give more sedation? Well, the biggest sign is tachycardia. If you have sustained tachycardia over 100 or so without another reason, assume they're in pain. Assume they're uncomfortable, medicate them if their blood pressure supports it. Another thing is called the Chiari cleft on your entitled CO2. How many of y'all know what the Chiari cleft is?
It's a sign your medication is wearing off.
Okay. Okay. Even more precisely, it's a sign they're starting to spontaneously overbreathe their medication. So your plateau here should be straight across and down. But if you have a little bump here or a little bump here or a little notch intermittently in between your breathing, think of it as almost like your third degree block where you have two different signals overlapping each other, right? If you have little notches, then that's probably the patient trying to do spontaneous breaths. If they're trying to do spontaneous breaths and you don't want them to do spontaneous breaths, right? They weren't already doing spontaneous breaths as part of where they should be, then that tells you need to maybe resedate them, reparalyze them, and give them some more opioids as well for pain. Follow me? Also, dopes. We talked about this. I'm going to talk about it again. You will see this in a test. Dopes, DOPES or ESS. We'll do just a simple 1S for stacked breaths. So remember that these are the things you check, whether you have a tracheostomy tube or an ET tube, and you need to have this indelibly printed on the back of your eyelids. If you are doing anything with advanced airways, this is your displacement, obstruction, pneumothorax, equipment failure, and stacked breaths. Please, please, please go down this list every time you have any problem after you put them on the BVM. Anytime you have any problem with anything related with your ET tube, solve this problem. And like I said, every intubated patient needs a BVM with a mask. We talked about it again. And I'll say it again. Every intubated patient, I don't care if you're going from the back of the ambulance into the ER bay, have a BVM with a mask with you. If you are going to the cath lab or you're going up to directly to whatever, have the BV or up to the ICU. That'll be the one time you don't is the one time you'll get stuck in the elevator and things will go south. Have it with you each and every time. And with that, are there any questions? By the way, that's one of the earliest ventilators from 1907. But anyway, you notice it is non-invasive with that mask right there. Are there any questions? Or 1927, not 1907, but any questions at all, guys? All right, so I apologize for holding you guys over. This is a complex topic. Just as a reminder, we'll be doing office hours tonight at 1800 hours. If you guys have any questions at all, something that pops up, question about discussion boards, something we talked about previously in different units, we'll have that. And these can be anywhere from 5 minutes to 30 minutes, depending on how the questions go. Or, so it's completely informal. It's completely optional. It's a different Zoom link. It's a different Zoom link, so make sure you click the right link. But it is in the unit, and I'll see you then if you choose. Otherwise, I'll see you online. Thank you very much, guys, and I'll hang out for any final questions.
Thank you.
Mm-hmm.
Thank you.
Yep.
Appreciate it.
Yep.
Have a good day, Steve.
Yes, sir. All right, guys. I'm signing off. There's nothing else.
Well, I might ask you some more questions
Okay.
about the ventilators in
Yeah.
the future, because I got one at Power County, but I haven't. Just kind of the settings on it just kind of confused me.
Okay, I'm all ears.
I was working with one of the paramedics there, and he didn't really know how to use it either. He just didn't have much experience with them.
Mm-hmm.
So we've just got to set like our inspiration pressure and then our expiration pressure and like the tidal volume. I know I was paying attention to you today in class, but I'm just not.
Okay, so most vents will have defaults for all those, and by defaults I mean set. You turn it on, it auto populates for the standard patient, the quote unquote standard patient. No patient ever is standard, right? But like our vents auto populate for adults at 500 cc's tidal volume, 10 breaths a minute, so a minute volume of 5,000. And the IDE ratio is 1:2. Just set up, boom, there it is. I don't remember off the top of my head what the peak airway pressure set at 60, correction, set at 30. The trigger set at 3, and whatever the other settings are. There's about 10 other settings, but they are auto-populated to be paramedic proof. And you already know how I feel about that. To plug and play, and that's the way they sell it. Is hey, it all populates all this, you don't have to do anything. So what we did is those charts, we actually created them so you could choose the right tidal volume for your patient and just open up and boom. So you could choose the right inspiratory and expiratory rate for your patient, or I to E time, which is pretty simple and stuff like that. So, and then we just practice with it.
Okay, thanks, Steve.
Does that answer your question?
Yeah, that does.
Yeah. So, do you know what vent you have?
I'm not exactly sure, but next time I'm down there, I'll check it out.
Okay, grab a picture of it if you whatever.
Yeah.
Yeah.
I know they just got it. It's at Power County EMS.
Okay, so what does it look like?
It's kind of like this blue kind of box. It's
I already
about
know.
this
Yeah,
big.
I know what it is. Hold on just a minute. Hold on a minute. So let me show you this.
So they just upgraded from an advanced EMT agency to paramedics within like the last 6 months.
So Z-Vent Impact. Does it look like, let me share my screen again. Does it look like that? It might be gray.
It's not quite that new. It had more kind of mechanical dials on it.
Okay, so is it like that one?
No, it wasn't like that. You see.
What you said is gray?
I mean, it just was kind of, yeah, it looked a lot like that.
Okay, so that's the auto vent, and depending on how many dials and which one it is, this is yeah, this is not my favorite vent by any stretch of the imagination. So, excuse my dog barking in the background. So this is the one. This is I mean, this meets the state standard for. Hold on, just a minute. I'll holler at my dog. Come here. Okay. I'm gonna shut my door. Comment. Come here, Coda. Come on. Here. Come here, Coda. Come on. Yeah. Yeah, I am. What's wrong, honey? Okay, give me kisses. Did they already head out? Yeah. Okay.
Bella's on my dog's on my bed.
Okay. All right, come here, Coda. Yes, please. All right, can you hear me now?
Yeah, I can hear you.
Yeah, sorry about that. So this one, can you see my mouse on here?
Mm-hmm.
Yeah, so there's your breath. It has preset for adult and child. And then it has your tidal volume, and it has very limited options. So you can see here it has 600, 500, 400, 300, and 200. And then it has, those are the pediatric settings, and then it has some adult settings underneath there in white. So this is not, I mean, it works, but yeah, it is what it is. It's compared to, for example, let's go back to what I was looking at just a minute ago. So this is the Zoll Z vent, which is basically just a recolored version of this old Impact right there that's been around in the military. Combat medics have been using this on flights for 10 years at least, maybe longer, right? So they bought it. They stuck a fancier. Oh, that's okay, girl.
Oh, hi.
Yeah, it's my Dane. So you can see here. Let me see if I can get this picture a little bit bigger. Nah, it's not going to give me a good picture there. So you have open image, a new tab here. We'll do this, see if this works. Not very good resolution, but for you have all your title, volume, your ID, everything all the way over here, and these soft keys to adjust each one of those features more or less independently. Some of those features are dependent on others, right? So they'll auto calculate, and then you have your alarm right here that'll tell you exactly what's going on with the patient over on this side. This is actually a really good vent. Even comes with its own compressor. I like these vents a lot. I was hoping we'd get them this year, but maybe in a couple years we'll get them. But this is perfectly appropriate for pre-hospital use, and it's pretty bomb-proof. Night and day difference between the two, but they're both considered automatic transport ventilators. So you can see this one, you can titrate to the patient's specific needs, and more importantly, get feedback. So on the other one, wherever it was, the auto vent, there's, I think there's a little friction alarm, a little rah, or something that will go off sometimes when you have reach a set peak airway pressure, but you can adjust that, right? You have no idea if they quit breathing. You have no idea if the amount of volume you're getting in is what you're getting out, anything like that. But with this one, you certainly have all that information. They're both considered automatic transport vents. Mm-hmm. So you can see how there's a huge spectrum of the vents out there.
Oh, thanks for teaching me that. I'm just trying to, I'm just not kind of unfamiliar with them.
Okay. Hold on a minute. I'll be right back. Okay.
It's okay.
So I apologize if you're still there.
Hey, no worries.
Yeah, sorry. Just my dog was going nuts. We had somebody at the door and she was freaking out.
No, it's all good. No worries.
Okay, so what else can I answer for you?
I was just wondering, I started that tracheostomy CEs course, but I didn't finish it. Is it okay if I just go back in and redo it again?
Yeah.
Do I need to just email you, or will you just see that I finished it?
So did you actually finish it?
I didn't finish it the first time.
Okay.
So
It will report when you actually complete it. You should be able to start it over and over again. If you
Okay.
can't, let me know.
Okay.
But I think I have it set where you have unlimited attempts.
Okay. Thank you.
Okay. All right. Well, all my best, man.
Okay. Take care.
Yep. Asa, anything?
No, I'm good. Thank you.
All right, man. Catch you later. Why won't this let me save?